Abfraction lesions. Friends, these are non-carious class 5 cervical type lesions that are usually seen on posterior teeth. I'm sure we all have come across this situation where a patient comes to us with these abfraction lesions complaining of sensitivity in that area. And how frequently do we land up doing some composite restoration for the patient, only to realize a few weeks or maybe even a few months later the patient comes back and the entire filling in totality has popped off. What do we tell this patient? Friends, it's important to understand that abfraction lesions happen because of bending of the tooth at its weakest junction, which is the neck. Because of this bending, essentially the enamel prisms tend to break off and you get a wedge-shaped cavitation at the cervical margin. This will almost always happen when a non-axial load is subjected on the tooth. We all know, friends, a tooth is very good in compressive load, but the moment the tooth is hit in a non-axial load, which is usually a tensile force, the tooth begins to bend and abfraction lesions come up. This will usually happen in a patient where the canine is not providing the guidance that it is supposed to. This could be because the patient does not have a canine tooth. It could be because the patient's canine tooth is not in its correct position, or very routinely the tip of the canine tooth is simply attrited, which means in such an individual there is a group function occlusion. The moment posterior teeth come in excursive contact, the elevator muscles increase their activity and the possibility of an abfraction lesion sets in. If you want your composite restorations in these abfraction lesions to survive, what is important is to provide the patient with canine guidance. If this is a patient in whom the canine tip is attrited, please go ahead and restore that canine tooth in simple composite. You do this with a total edge technique, your composite filling there will survive. You may do this on the palatal aspect, you may do this on the incisal edge. The moment you give your patient a canine guidance, the elevator muscles relax, thereby the composite also survives. What this more importantly does is it separates the back teeth, it disoccludes them. If the back teeth are disoccluded in lateral excursion, there is no longer a tensile load that they are subjected to, which means the bending forces are taken away, and now your composite restorations, not just at the cervical aspect of the posterior teeth, but also on the canines, will serve the test of time. Worst case scenario, if on the canines the composite wears away, come back and repeat it. Or you may eventually actually even do a porcelain canine laminate, not on the labial surface but on the palatal face. This would not be an aesthetic laminate but a functional laminate. This guidance surface will not wear away and will serve the patient for many years together. Hope again this small little tip will help you improve your practice. Until we meet again, friends. Bye bye.